Thank you very much. So thank you for the invitation. It's a pleasure to be here. I'm going to talk about bones and how we might maintain bone health in women aging with HIV in Africa in the public healthcare system. I have no conflicts of interest, although I should declare that I chair the National Osteoporosis Guideline Group, so I write the guidelines for the management of osteoporosis with my colleagues in the UK. So when we're growing as adolescents, we are growing our peak bone mass, and we achieve that around the age of 30. And then we have about 5 years before we start to lose bone, a little bit, 0.3 to 0.5% of our bone mineral density every year. And then as women, when we go through menopause, we have an accelerated loss of bone density over about a 10-year period because we lose our estrogen. And unfortunately, if we have a challenged adolescent growth period because either we're born with HIV or we live in a nutritionally challenged environment, we may achieve a compromised peak bone mass. And at some point, as we lose bone as we age, we enter this window of fracture risk. And I'm talking there about fragility fractures. So these are fractures from low trauma, so a fall from a standing height or less, and you fall and you fracture. So if we think about aging around the world, this part of the world is expected to see the most rapid growth in the number of older people over the next 20, 30 years. And it's these countries in red that are in Africa that also have the lowest gross national income per capita, i.e. potentially the least resource to provide for this burgeoning older population. And what we know about age is that there is this exponential increase in the risk of fragility fracture. So the commonest fragility fracture is of the spine, first fact. Often under-recognized because spine fractures don't come to clinical attention, but the vertebral fracture is important. And you can see here an exponential rise in hip fracture incidence. These are data from the UK. There's no particular reason why there should be any different anywhere else in the world. And what we know, because of this growing population, older population here, together with this increase, age-related increase in fracture incidence, that Africa, in both men and women, is projected to see the greatest increase in those people who are at risk of major osteoporotic fracture in the next 20 or so years. By major osteoporotic fracture, I'm talking about hip, humerus, vertebra, and wrist. That's just the nomenclature. Now, if we wind the clock back to 1999, the WHO rather arbitrarily, in my opinion, defined osteoporosis based on a bone mineral density measured by a DEXA scan. And they said that osteoporosis is 2 or 2.5 standard deviations of bone density below what you would expect it to be at peak bone mass in a young adult population. But the first and really important fact is that most fragility fractures occur in people who have a normal BMD T-score. They have a T-score above -2.5. It's not all about bone mineral density, just thinking about the point that was asked before lunch. So here are some data that show that. So on the x-axis, bone mineral density T-score, going left to right, so on the right-hand side, the lowest T-score, and on the y-axis, you can see fracture rates. And clearly, the lower your bone density, the higher your fracture risk. But if we look at the distribution of people who fracture, actually it's only the tail of that distribution who have a T-score less than -2.5. The vast majority of fractures are occurring in people who have a normal bone mineral density. So why is that? Well, it's because there are so many other things that contribute to fracture risk beyond bone mineral density. Mass, so density is mass over area, is just one component in the things that cause fragility fractures. And you can see they're all the things that make people fall over, they're all the things that impair bone quality, and then there's a load of stuff in the middle as well, and HIV would fit in there. And what we need to realize is, obviously, we talked about this already this morning, there are an increasing number of women living with HIV transitioning through menopause into older age, 2.6 million estimated over the age of 50 living with HIV in sub-Saharan Africa. And we know, at least from this systematic review of 21 studies from high-income countries, that HIV is associated with increased fracture risk. There were no studies in this systematic review from this part of the world. We have ourselves done a study of of osteoporosis, of T-scores in South Africa. And what we found in this rural dwelling, older population of women aged 50 to 80, that those women who were living with HIV, 37% had a femoral neck BMD T-score less than -2.5. And this is obviously in a country where TDF is first line, and we know TDF can adversely affect bone mineral. And I think that's probably the reason for that. Does this translate to increased fracture risk? Well, we don't know in this particular data set. We did a very similar study in Zimbabwe. We also saw in this is a young population, 40 to 60, so half of them will be premenopausal. We saw that 21% had a lumbar spine T-score less than -2.5. And when we asked these women whether they'd had a fracture or not before, the women who were living with HIV more commonly reported having had a fracture, more commonly reported having had a major osteoporotic fracture, and none of these women had ever been offered any anti-osteoporosis treatment. None. Now, if we move back to South Africa, this was a study that was done in just the general population, so not necessarily HIV specific, but obviously there's a high prevalence of HIV amongst these people who contributed to the study. And here in South Africa, you see, just the same as everywhere else in the world, this exponential increase in the incidence of hip fracture with age. But the nice thing about these data is we were able to use those to calibrate this tool called FRAX, which is at the bottom of the slide. So zooming in, so FRAX is a fracture risk assessment tool. It's available freely online. You can Google it now, you'll find it. And it's country specific. So here, this is the South African tool. And here I've put in somebody who's 60, a woman, weighs 65 kilos. I'm saying that she has a secondary cause of osteoporosis. HIV is a recognized secondary cause of osteoporosis. And then you click the calculate button, and it calculates a 2.5% 10-year probability of fracture. And then you're like, okay, well, what does that mean? Is that high? Is that low? Do I do something about that? Don't I? What do I do? So in every country, one has to decide what is the threshold of probability above which you're going to do something and below which you're going to reassure and give lifestyle advice. And so most countries around the world are developing pictures that look like this. So these are intervention thresholds, and these are based on the frequency of fracture, the competing risk of death, and the kind of population structure within a given country. And this is the model that I'm currently working with the National Osteoporosis Foundation of South Africa to just advise, really, so that they can make the decision about where South Africa puts its intervention threshold. So this is for the Black South African population. So you can see the intervention threshold indicated here, and you can see up until the age of 70, the risk or the intervention threshold is set at the risk equivalent to that of a woman of that age with a prior fracture. So that's based on the premise that if you have had a fragility fracture, you would treat that person with an anti-osteoporosis treatment. Okay? And I think that that's fairly widely accepted. And then beyond the age of 70, we have a flat threshold, because otherwise you're disadvantaging older people. And then you can decide, you can say, okay, if you're in the green, you're low risk, we're going to give lifestyle advice. If you're in the red, you're high risk, this is where you get on and give some anti-osteoporosis treatment. And if you're in the yellow bit, then you might need a DEXA scan. And this came up this morning. You know, there's only 2 DEXA scans, I think was said in Kenya. It's the same, and in Zimbabwe there's one that's accessible. So we can't have a system that is dependent on the accessibility of DEXA scanning. And we have to come up with other pragmatic solutions. And that's where this intervention threshold comes in. If you're above the intervention threshold, you treat. If you're below the intervention threshold, you reassure. And you reassess in a couple of years to see if things have changed. And you can calculate those intervention thresholds quite precisely for a given country. And these are those for South Africa, as I say. The other thing that is important to consider, so where you may not have DEXA, you often have plain radiograph facilities. And I would urge you to consider using lateral radiographs to look for vertebral fractures, because they indicate more fractures to come, the vertebral fractures, and they're associated with pain often. So it's acute, it can be anywhere in the spine, it often radiates round to the waist, it's usually constant, exacerbated by standing, often by leaning a little bit forward like you're doing when you're doing the washing up. That's often really quite painful if you've got a vertebral fracture. Relieved by lying down, it can be described in many ways, but it often crescendos until you have to lie down. So when should you x-ray? You should x-ray if the pain is as I've described, or somebody's lost height because their vertebrae has gone clunk, or if you do find a vertebral fracture, that will prompt you to do something for that patient that you're not otherwise currently doing. And what we're trying to stop here is this thing that's called this osteoporotic career, where you have a fracture, you don't treat, you have another one, you don't treat, you have another one, and each time you're accumulating morbidity with these fractures until you may well have a hip fracture. You know, in the UK, that's got a 28% one-year mortality. And you've accumulated a lot of morbidity by that point. So you want to intervene, get people on treatment, prevent the next fracture. So these are my recommendations when advising about lifestyle and dietary measures. A healthy diet, it needs to include protein. Your bone is protein that has mineral within it. So you need to eat protein. It doesn't have to come as meat. It can come as pulses. But protein is important as we're getting older. Minimize alcohol, avoid smoking. Dietary calcium. So in Zimbabwe, Zambia, we have kapenta fish, but you know, freshwater, small fish, high in protein, high in calcium, great for your bones. Dried fruit, dairy if it's available. Expose your skin to sunlight so you can make vitamin D, and regular weight-bearing and muscle strengthening exercise, really important. And in Zimbabwe, we've co-designed, co-produced information resources for women around menopause. There's a section on HIV, there's a section on how to eat healthily, and we've generated YouTube videos in Shona and Ndebele. And similarly, in South Africa, we did the same thing working with women in Soweto. These resources are available through the South African Menopause Society in 5 languages. If you want to adapt these for use in another country, please talk to me. Very open to business. We're looking for people that might want to take those and adapt them to other settings. So when should we be assessing fracture risk? My suggestions would be when a woman reaches menopause, so average age is 52, that we should assess fracture risk and then do so every 2 to 3 years, sooner if somebody fractures. And I would use, in the absence of if your country doesn't have its own FRAX tool, then I would use the Black South African FRAX tool. Because it's probably the best proxy. Here, certainly it is in Zimbabwe. Always examine the vertebrae on routine x-rays. So you're doing chest x-rays for various things, TB, whatever. Have a look at the vertebrae. Are you missing an incidental vertebral fracture? Will it change your management if you identify that? Think about lateral, you don't have to do AP, but lateral radiographs of the lumbar and thoracic spine in postmenopausal women with acute onset back pain and or a history of height loss or kyphosis, particularly if they've had glucocorticoids, because glucocorticoids reduce bone density very quickly when you start them. Consider non-HIV causes of fragility fracture as listed, and assess falls risk. Somebody's fallen in order to fracture. Why did they fall? What can we do about it? And consider balance and muscle strengthening exercise. So my recommendations for anti-resorptive treatments, which are cheap, is any postmenopausal woman who's had a fragility fracture, especially of the vertebrae and hip, start treatment with an anti-osteoporosis treatment, and do it promptly because your risk of refracture is highest in those first 18 months after your first fracture. If you are starting somebody on higher dose glucocorticoids, don't wait for a DEXA scan. Get on and start the anti-resorptive therapy at the same time that you're starting those steroids, because it'll change bone density rapidly. And then if you are using the Black South African FRAX model, then I would suggest that if you have a major osteoporotic fracture probability of above 3 and you're 50 to 60, above 4 and you're 60 to 70, above 6 if you're over 70, those are the sorts of thresholds above which you would want to start some anti-osteoporosis treatment. And what do I mean by anti-osteoporosis treatment? I'm talking about anti-resorptives. I'm not talking about calcium vitamin D on its own. It's not enough. I'm talking about an anti-resorptive medicine, and the 3 cheapest and most widely available are HRT, very good for your bones. So if somebody's under the age of 60, they've recently had menopause, maybe they have symptoms, HRT is very advantageous for your bones. Oral alendronate weekly is another option, widely used. And intravenous zoledronate, 5 milligrams, and if you don't have that available, 4 milligrams is fine, and you can give it every 1.5 years. Zoledronate works very well. It reduces clinical vertebral fractures over 3 years by 75%, hip fractures by 40%, and if you give a single dose of zoledronate, it puts up bone mineral density and it'll stay up potentially for up to 5 years. So if you're, difficult for patients to come back to clinic and they don't always attend, actually they're kind of safe if they've got some zoledronate on board. So my final slide is my top 10 take-home messages. So women aging with HIV are at increased risk of fragility fracture. When a woman reaches menopause, 52, I would assess fracture risk, and I'd do so every 2 or 3 years, sooner if she fractures. Black populations in Africa actually have similar bone mineral densities to white populations in Europe and the US. So the reference data that you should use if you are doing a DEXA scan to generate a T-score is the white reference population, not the black reference population, because that population is a North American black population who have a higher bone mineral density, and you'll otherwise overestimate your prevalence of osteoporosis. Most people who fracture have normal bone mineral density. Bone mineral density is not widely available in many parts of the region, but there are other ways of assessing fracture risk. Actively look for vertebral fractures, because if you see one in a postmenopausal woman, then you can put somebody on treatment and you don't need a DEXA scan. The basic antiresorbatives, I think, are cheap, so I'm talking about 10 to 12 USD per year for HRT, alendronate, zoledronate, so they're generic. Calcium, vitamin D supplements on their own are not antiresorbatives. They're not enough if you want to give somebody an antiresorbative. You can't use FRAX intervention thresholds from very different countries, so don't just take the US intervention thresholds and think they apply here, because the populations are inherently very different. And lastly, I think osteoporosis medicines should be on the WHO essential medicines list. They're not, and at least they should be on country-specific lists. And with that, I'd like to thank the many collaborators with whom I work. Thank you.